All right, guys, we're going to talk about geriatric emergencies real quick, which is like the older age population. There's not going to be a ton of stuff on the test about it, and it's not overly complicated, but especially if you don't have a lot of interaction with older patients, there's a few things we have to talk about just to kind of be mindful of as you go forward. So we are saying that the geriatric population is over the age of 65. And basically, I can sum up the entire presentation in that last bullet, which is just the natural aging process results in a decline in the functioning of all body systems. It's just the unfortunate part about living older. So the issue is, though, overall with that is there are some people who are 50 years old and they can barely walk, and they have all these chronic diseases and conditions, and they're on oxygen. And you also have people who go skiing into their 80s. So the issue is that a lot of, and I've seen it, a lot of paramedics and medical people, they end up treating all old people the same. And unfortunately, there's just a huge spectrum, and that we really can't do that. So two of the biggest things you might see in this population are going to be issues with hearing and sight. So hearing impaired, or sometimes called deaf, sometimes they might need to use a hearing aid. And that will be great if that's what they want to use. If they would rather communicate with paper and pencil or whatever it is, that's fine. Just remember to not yell at them or anything. For the most part, if they have hearing aids and stuff, they can hear you. So you can just ask, hey, can you hear me okay? And that way that can save you a lot of embarrassment if you start. So if you're for visually impaired, if you're in the house and you see lots of eyeglasses, a cane, service dog, those are all things that might lead you to some sort of vision issue. So with these visually impaired patients, just make sure you tell them what's going on all the time. It'll make them a lot more comfortable and a lot more calm if they feel like they know what's going on. So overall, just with all these patients, just identify yourself, speak slowly and distinctly, and explain what you're doing. The big thing that I've seen is that middle point, do not talk about the patient in front of the patient. I've seen that a lot where people get into either a hospital room or even like on a 911 call, and they just kind of stop acknowledging that the patient's in the room, and they're like, oh, well, he did this and he did that, and they don't ever talk to the patient even though he's right there. So make sure we include the patient in all our treatments. So these are just we're going to go through real quick and catalog some of the issues as far as the rest of the body. So the muscles are going to lose strength. The intervertebral discs are not going to be as well, or not going to be as full and strong as they used to be. So it can actually cause a loss of height, curvature of the spine, loss of stability. Falls are actually a bigger concern with this population, just because bones have issues. So they're going to be slower, which is easy to get frustrated about, but just try and slow it down and just take a breath and realize that they're moving on. So fractures, the big issue with the fractures here is their bone density has been reduced, usually due to osteoporosis, especially in women. So you can actually have fractures of a bone pretty easily. The big thing we're worried about is hip fractures, and we all make jokes about that, like, oh, you broke a hip, but old people do break hips, and they usually don't recover from it. So a lot of bad things can happen in fall. So these are just some other kind of stuff we would have talked about, just ideas of what are some of the things you might encounter. They're also going to be less likely to, or less able to fight off diseases and infections. So a younger healthy person can get pneumonia and they could be clear in a week or a few days potentially, and an older person may get pneumonia and then may never recover from it. So that's also an example of why COVID is so much worse in this population, because of these things we're talking about right here. So cardiovascular diseases, they can, the potential for those goes up as you get older, just because you have built up toxins in the fatty deposits on your arteries and those kind of things. And those things can also lead to strokes and abdominal aortic aneurysms. And they also don't feel pain as well as other people, so they may not even know that they're in trouble. So respiratory diseases, the alveoli loses some of their elasticity, and the muscles associated with breathing decrease. And then you can have like chronic diseases or acute diseases. So COPD, chronic obstructive pulmonary disorder, that's something that they can live with forever. But if they get a pneumonia or something on top of that, now they could die from it. And then that's an example of where a chronic condition meets an acute condition. And of course, the best example would be COVID. And I think here we can see why the elderly population does not do as well with COVID. So Basically, we want to examine the patient, get them medical history, and just understand that these older populations, the medical history might take a long, long time. Treat the symptoms, take them to the hospital. Cancer, nothing that we can really do about it, but it's something you're going to run into. Just understand that usually they'll have like a doctor or something that they'll be have been treated at some point. So usually the patient is going to know plenty about the patient. Altered mental status, this is a tough one in LD population because it could be anything. It could be lack of oxygen, it could be lack of sugar, it could be hypothermia, it could be a urinary tract infection, it could be a small stroke. These altered mental status patients can usually be pretty tough to deal with. Medications, also understand that they take a ton of medications. Most elderly patients who are released in and out of healthcare regularly, as in they have a doctor, that kind of thing, they will have a list of medications. Usually it's like a paper list, they keep it in their purse or something. And so you ask them about medications and just ask them if they have a list. So we're trying to figure out, when you look at that list, which medications they're on. You can learn a lot about the patient by seeing what medication they're on. And then usually we want to bring the medication test to the hospital. So long-term care patients, these are people who have some sort of condition and they've had to manage it for a long time. And so that might be they're on a ventilator, they're on some sort of nasal cannula, oxygen thing, they're on a breathing tube, they're on all sorts of different monitors. So these patients could come with a lot of extra stuff with them. And some of these devices are very complex. If you look at like a left ventricular assist device, that's something for like a heart condition, but you can't actually do CPR in that. They're actually worried that if you do CPR with an LVAD, you're going to dislodge it and the patient will definitely die. So there's some of those conditions that older people have that you may not know about. So always ask a lot of questions, get a very good history about what's going on. So remember, as an EMR, we're here to address the immediate problem. Take those steps, try not to get overwhelmed, and really then we're going to try and evacuate that patient to the hospital. Depression is the most common psychiatric condition in older adults, and I guess you could understand why. Their friends are dying, maybe they've lost their ability to drive, those kind of things. Things they've been doing for 70 years, they can't do anymore. So depression is something to worry about, and also that living in a nursing home can make that depression worse. Okay, so you take in that depression, but then you also throw it in with just the overall declining health and the chronic health conditions and terminal illnesses, and it can be a pretty sad area. I personally, old folks homes, nursing homes, get pretty depressed when I go in there, just because it's usually not a super positive experience being in there. Suicide is also a result of that, men usually more so, but understand there is a big suicide risk with the J population. So you want to listen to them, and you want to look for those red flags about suicide. And if they attempted suicide or they're considering suicide, you definitely need to arrange to transport that patient. So dementia is just a decline in mental function, and things like reasoning, judgment, comprehension is a big one. So they just don't understand. Their brain just doesn't work as well as it used to. They just don't understand what you're trying to say. Or conversely, they might know what to say, but they can't do it. Like their words will not come out. So communicating with some of these patients with dementia can be pretty tough. You can have small strokes, hardening of arteries. Some of it's genetic. There's lots of causes for dementia. The most common form of dementia we're going to see is Alzheimer's, and it affects millions of people in the United States, and it's very tough to deal with. This is, as far as emotionally, it's very difficult to deal with because the patient isn't always there, so it's hard to know where the patient is at the time, and if they know who they are and if they can care for themselves, those kind of things. In the later stages of it, they may be unable to walk, they're going to lose bladder control, the inability to swallow. It just really depends on how far they are on that disease process. If you've been called to like a 911 thing, you're in someone's house, try to use the family to help you through it. They're the best asset in this environment. All right, one of the last things we'll talk about is hospice care, which is basically it's a conglomerate of different healthcare options. So to provide physical, emotional, spiritual, social, economic care for terminal illnesses or who are otherwise expected to die in about 6 months. So there's lots of things that go in this, and it's really, we call that end of life care. And usually it's a lot of medications. They do some patches. So really, if you ever hear hospice care, just understand that's end of life care. Advanced directives. So this is a document that outlines the care a patient wants to receive if they're not able to make their own decisions, which is not necessarily DNR. DNR just says do not resuscitate, whereas an advanced directive is I want this medication, I don't want that medication, or I want to be revived, but I don't want to be intubated, or you can kind of have a wide range of things you can specify on your advanced directive. The thing about these though is it really is state dependent and like county dependent, agency dependent. So just make sure that if you're working in an area like this, make sure you understand how they handle these advanced directives so you don't get yourself in trouble. Elder abuse is a thing that happens, surprisingly, it can actually happen from a spouse, a family member, or a caregiver. And it actually has been physical, sexual, or emotional. It's kind of hard to fathom why someone would want to abuse another person, but there's lots of things that people do that are hard to fathom. So we want to look for these signs and symptoms: bruises, burns, trauma, signs of neglect. Bruises in different stages of healing is one that shows that it's been a long-term process. If you suspect elderly abuse, that's something where we get law enforcement involved. Okay, so you're not going to be, Magnum PI on your own to investigating this. If you think there's a few red flags and it's worth investigating, then call it up to law enforcement and they take care of it. So that is it, guys. Just a quick down dirty lecture on geriatrics, and really it's just a decline in overall body functioning.